Thank you, Santiago, for the introduction. So, I'm going to talk to you about one of the 9 chapters here where what I'm going to try to do in the 14 and a half minutes that I have is kind of tell you how the social protection system in Honduras is supposed to work, then tell you how it actually works, and what can we learn from that and where can we go from there. So, like we said, this is part of a larger project, and one of the things I'm going to focus on is how does the de jure expectations of the system, how they actually reconcile with how this actually works in practice. And at the end, probably this is a work in progress. So there is there are not necessarily policy recommendations that come out of this, but more a discussion, a general discussion that takes on many of the things we've been talking about during this conference, like whether, do we need to expand coverage of certain programs? Do we need to change the amounts that we're giving in certain programs? Which are valid questions, but they're not as direct as one would think. I mean, it's not necessarily an issue of let's cover everybody, because that we need to fund that too. But I'm going to get to that in a bit. So let me just give you some background. So social protection in Honduras was established around the 50s, later than in other countries in Latin America and the Caribbean. Like in some countries in Latin America, they created an institution that deals with Social Security. And here is the Honduran Social Security Institute. But as you would imagine, in many developing countries, there are different aspects of social protection and social insurance that are the purview of other ministries. And everybody interacts without interacting, because everybody kind of does what they're supposed to do, but that also interferes with other things so let's say, I'm going to show you this in a bit, but the Honduran Social Security Institute provides health services to workers from a contributory system, but there's also the Ministry of Health that also provides public health services to people independent of whether they cover wages. So there you have 2 different institutions that deal with health and create basically 2 different health systems. Social protection has remained mostly unchanged since 2001 with some minor reforms. And here's so if you saw the title that I put to this was like towards effective social protection. So the thing is, Honduras is at a crossroads right now. So in 2015, they passed a law that was supposed to broadly reform the social protection system in Honduras, and it passed through Congress, but it was never formally reglamentada, actually put into practice, because it was declared unconstitutional. So I don't have time for all of this, but let's say that law in 2015 was approved by a right-wing government who was ousted in 2021 by a leftist government. So that leftist government said that that law that they approved in 2015 was unconstitutional and that they were going to reform it. But so they eliminated that law that was going to reform, and they went back to the system that was prevailing before that, which is the system from 2001 that I sort of mentioned. As far as we know, there are people who are working on this legislation, and there have been some leaks and some rumors as to what's going on, but nothing concrete. So I'm not going to talk about speculation for the moment. So just let me tell you, how is social protection expected to work? So basically, social protection is segmented into 2 components: a contributive part where certain workers must contribute a percentage of their wages in exchange for certain services. I'm going to tell you what services those are right now. And then there's a non-contributive part, which are the workers that are not required by law to contribute, plus everybody who's not in the labor force, right? And additional to this, you can also, Hondurans can also receive poverty alleviation if they fulfill the targeting criteria. So you could be a contributive worker, but also poor, and you can receive contributive services and poverty alleviation. So here's kind of a graph summarizing how the system today, which again, this is the system that was in 2001, has been more or less since 2001. So you have everybody who's out of the labor force should not contribute and is covered by non-contributory programs. Then workers, you can divide them into more or less these four broad categories, and you have wage earners in the private sector and public sector, and those are compelled by the law to contribute, right? They have to give a percentage of their wages, and their employers also give a percentage. And then the self-employed, domestic workers, and unpaid workers are not required to contribute. So one of the differences with the law that passed in 2015 that was declared unconstitutional was that some of the self-employed were actually forced to contribute, okay, by an additional characteristic. And how much should these people contribute? So again, wage earners in the private and public sector are compelled to contribute, right? How much should they contribute? So to receive health and maternity benefits in total from their salary, they would contribute 8%, which is mostly paid by the worker, a part by their employer, and the government adds a 0.5% solidarity contribution. There's also a component for disability, old age pensions, and death allowances, which totals to 6.5, and then a professional risks, which is an insurance against workplace accidents and illnesses. So in total, if you sum all of this, about 15% of a worker's monthly wage would go to the contributive system if they are wage earners in the private or public sector. And this is kind of an important thing because this is something you could see in other countries. So in other countries, for example, like Colombia, there is a minimum level at which a minimum income at which you should contribute, which is usually the minimum wage, right? That obviously assumes that all workers earn at least the minimum wage or more. But in Honduras, that doesn't happen. Actually, the contributive system, you can contribute for less than the minimum wage. But there's going to be a maximum value, which is going to make things a lot more confusing, you'll see. So what are the benefits? Basically, health and maternity coverage gives you medical services to affiliated workers and their beneficiaries. So if I'm a contributing worker and I have a family, my family gets medical services as well, right? The disability, old age, and death allowances are insurance against accidents or illnesses, incidents that result in death, or a pay-as-you-go pension scheme for retirement, which has several requirements. You need to contribute for at least 15 years. Doesn't have to be consecutive. And then you have to fulfill the legal pension age, etc. The insurance against workplace accidents and illnesses, like I said, medical attention, and a subsidy. And allowances, if they contribute to this one up here, they also get like a pension, let's say. Important. These are two very important assumptions that the system is making. So right now I'm just telling you how the system is supposed to work, right? First is that all workers who are expected to contribute, so all wage earners, should fulfill their duties, right? That's kind of the first big assumption. Second one, that contributing employees earn at least the minimum wage and that employers comply with all the labor regulations that they have. Okay, so that's the workers that are supposed to contribute. So if I go back to all of this is basically wage earners. So what happens to the rest of the people who are not required to contribute? What do they have? In theory, the social protection floor is very limited in scope at the moment. The reform in 2015 that was declared unconstitutional and the rumors about the new reform are trying to set a social protection floor that's a little bit more generous. But again, because that's very speculative, I'm not going to get into all of that. So the one program that does exist is a public health services provided by the Ministry or Secretariat of Health, which is basically you can go to any public hospital and receive medical attention, right? Paid by funds from general taxation. And in theory, a person from the bottom 1% should receive the same services as somebody in the top 1%. In addition, there's poverty alleviation programs. Honduras is one of the poorest countries in Latin America. So about 43.4% of the population was in extreme income poverty and 67% under the moderate poverty line. These poverty rates have been very stable over time. I mean, there's been very, very little poverty reduction over time. And like in many countries in Latin America, the main form of poverty alleviation have been cash transfers, primarily conditional cash transfers. And several of the prevailing impact evaluations were very promising in the short run, but not as promising in the long run. So that was how it was supposed to work. So now let me show you some things about how this is actually working. So here's a table where I'm separating the people who should contribute and the people who could contribute, who are not compelled to contribute, but they may contribute voluntarily, which I forgot to say. And this is how much of the percentage of the workforce they represent. So wage earners represent about 45% of the total workforce. 100% of them should contribute, but about 30% are actually contributing, right? So there you have the big divide, right? There's 70% of the people, 70% of the people who should be contributing are not contributing, right? So there you have like a big indicator of informality. Something's not happening here. And this is from household surveys. But if even I get the administrative records from the Honduran Social Security Institute and I see the amount of people who pay, who they report pay, and I divide that by the number of salaried workers in the country, that gives me 40%. So again, there's a lot of people who should be contributing who are not contributing, right? And obviously the question is why? So there's several reasons why, which we are going to get to in the paper, but basically the first one is, remember I told you there is no minimum amount to which you contribute. So even if I have the lowest wage, I can still contribute a percentage of that, but there's a maximum value. What that effectively does is that the people who earn more, so this axis shows earnings, monthly earnings in minimum wages. If you can see this, the people who earn one minimum wage or less give about 14% of their salary to the contributive system. But if you earn more, as a percentage of your salary, you're contributing less, right? So that's important because effectively it seems like as a percentage of your salary, and this is important, right? You end up paying less for all of this. And let me focus on old age pensions, for example. So I'm going to show you by quintile how many people are receiving an old age pension through the contributive system, right? Through the data. And no surprise, in the richest quintile, there are more people who receive a retirement pension with the pay-as-you-go scheme. It's still 6%, right? It's very, very little. And the blue line, what I'm showing you is the amount of the pension that they receive, right? So in the poorest quintile, about 1.3% of the people manage to get a retirement pension, right? And that value is 0.3 of a minimum wage, really, really small, right? A minimum wage in Honduras is about 400 USD per month. It's high in general. But what I wanted to show from this graph particularly is that the people who can retire in the contributive system tend to be those workers who contributed who are in the richest households, and they also receive more generous pensions, right? The people who are in lower quintiles have a lower probability of getting a pension and also a lower amount of getting a pension. This is also, so basically I told you that there are two health systems, and two health systems, basically what they incentivize is bad behavior, right? I mean, if I'm a worker who's a wage earner and I'm compelled to contribute, but I can also get free services in health if I went to a public hospital, those incentives make me say, like, why should I pay for something when I can receive it for free? And one way to sort of show that would be kind of showing this table, comparing the contributive system and the non-contributive health system, more or less what the annual net benefit is. So here's the eligible beneficiaries in the contributive system and the non-contributive system. Here are the affiliates. This is how much was spent on health in the contributive system and the non-contributive system in terms of GDP. And as you can see, it's more or less the same, in terms of percentage. And then I can calculate an annual expenditure per affiliate here and how much that affiliate has to pay annually. And just, this is a very crude calculation. It's nothing fancy. If I compare the net benefits, actually, it's a lot better for me even if I needed to contribute, I should just go to the public health system. Just making that simple calculation. Honduras does invest a lot in poverty reduction. So look, as a percentage of GDP, for national funds, external funds, debt relief, etc., 23% of GDP is dedicated to poverty programs. But coverage is only 1/3 of poorest households, and the amounts are also less. Let me just go to conclusions. So sorry for taking too much time, but basically, social protection in Honduras is not working as it's supposed to work, right? So there are certain guiding principles that we should have. Yeah, you know what? I'm going to stop. We can discuss all of this later. But the question is, what can we do to eliminate these bad results? That's kind of where the direction is going and where the other country studies are also going to go. So.